Dr. Meenal, but the actual leadership is yours. So thank you for leading the way and starting the first DASG school. To everyone who is here with us from India, from beyond, across Asia and Africa, a warm welcome. And you are the leaders of today, the leaders of tomorrow. But before we ask Dr. Helena to begin her talk, what is special about today? Today is the 14th of February. Anything special about that? Valentine's Day. So in Nepal, Dr. Robin, how do you say Valentine's Day in Nepali? And Dr. Yadav, is that right? Is the translation correct? Yes, okay, so that's fine. So we've got off to a good beginning. Now that's what leadership means. But the sun rises in the east, so let's begin with the east. Anyone from East Asia, would you please raise your hands? Anyone from east of India? Bangladesh is also east of India. Dr. Zad Khan sir, raise your hand, sir. No, we are bhai, okay. Same blood. But anybody else? Yes, where are you from?
Kolkata.
Kolkata, okay. So that is the eastern part of India, so warm welcome. So in Bengali, how do you say Happy Valentine's Day? Okay, and anyone who can vouch for the translation, is that right? Dr. Khan sir, is that right translation? Okay. Anyone from the Middle East? Central Asia? Yes, where are you from, madam? Uzbekistan, so warm welcome. And actually, Uzbekistan has a very important place in Indian history because the entire Indian history was changed by one particular gentleman from Uzbekistan. Anybody knows who his name was? So there is something known as the butterfly effect. We'll ask Dr. Helena to talk about that, and let's take the butterfly effect as our theme for the next 35 minutes. The butterfly effect states that if somewhere in Uzbekistan a butterfly flaps its wings, that can create a tsunami or a cyclone in East Asia. So one action leads to another. This is what happened in Uzbekistan when a gentleman called Babur was orphaned actually. He moved from Uzbekistan, found his way to Iran and then Afghanistan and then India, and he created the Mughal dynasty for us. So that is butterfly effect. If he had not been orphaned in his village in Uzbekistan, we might not have had the Mughal dynasty. Our history would have been totally different. That's what butterfly effect is. What does butterfly effect mean for us today? What it means is that all of you are here with us. We are here together with each other. The key word is together. When you saw Dr. Dhruvi talking about how to set up a diabetes care clinic, she never said you can do it alone. You need many people with you. That togetherness, how do we add leadership to that? Whom should we lead? What should we lead for? If we can understand that, then we can create a butterfly effect for diabetes care, for healthy diabetes outcomes. With that, let me invite Dr. Helena. Dr. Helena looks after the International Society of Endocrinology. So, madam, the floor is yours. What do you think of the butterfly effect and your career in endocrinology? And what advice would you have for all of us?
Thank you, everyone, and thank you very much for the invitation to come. I have to say it's a lot easier to come to India from Australia than it is to go to Europe or to North America. So thank you very much for the invitation. So the butterfly effect, what has that meant for my career? I'm sure there are many times that minor things happened that then had longer implications, and then there were major things like my young children that had very big implications in my career. But I think for me, one of the things that happened very early is that I was offered an opportunity to do leadership training. This is not something I would have normally done in my career. And at the time, there were very few female endocrinologists in Australia. So it was an opportunity, perhaps one of those butterfly effect moments, Sanjay, that led to a much greater focus on leadership. And most of my career, I still do clinical practice and have led in fact, the largest diabetes unit in the country. But I have very much and increasingly focused on leadership, bringing groups of people together across the world to make a difference. I believe from Sanjay that the audience in this forum are people who have significant leadership roles and influence in your region, and I'm going to assume that when I'm talking here. So one of the problems we all have when we want to improve healthcare And we've had a really nice example of what you can do in your own practice and how you can set up multidisciplinary care in that context. Obviously, there are many other players in that context. There are community health workers, there are hospitals, and in every different health system and country, that is different. For example, having done studies with Dr. Nikhil Tandon from AIMS across Bangladesh, Sri Lanka and India, I know that your health systems are all very different, even within the South Asian region. And I'm sure from one region to another within India and in other countries they differ again. But one of the problems we often make when we try to drive improved healthcare is that we just think of our own practice or our own hospital or our own team. And what we know is that's not enough. For example, I've had the privilege of being involved in many global alliance of chronic disease projects that have been funded in India, Bangladesh, Sri Lanka and Pakistan. And the learnings from those large projects are the same as the learnings from all other projects around the world around diabetes and diabetes prevention, which is you cannot do it alone. And the projects that work because the leaders who are working in diabetes work with their community, work with their health services and work with their government. And when they start to work with other people, they can make a difference. So we're going to talk a little bit about thinking about the parts of the system that may not be your individual practice or your individual hospital service. What is the real system that you are working in? Because if you don't understand it, it's very unlikely you're going to be able to change it. If you want to make a change or you want to situate your practice or your health service in that system and make it an integral part of that system, so it's not just about your patients as your clientele, but also about how you work in the healthcare system, you need to understand it. You need to bring all those teams together and make sure that everyone agrees on the problems and the priorities. For example, you all wrote down before what the 3 top things you think are most important in your context for good diabetes care. The challenge is that is our perception of what we think is most important. But if we don't know what is most important to our patients, if we don't know what is most important to fit into our health system, if we are not part of the solution, we're just another part of the problem. So understanding what the collective problems are and responding to them means that you will be personally in a better position, but your service will be better and your outcomes will be better. The next thing is to make sure we use best evidence and that we understand how to drive change. So one of the challenges we have, and this little cartoon down there is an understandoscope, meaning we all look at a problem and understand a problem from our own perspective. And presuming most of the people in the room are doctors, we think we know what it's like to live with diabetes. We think we know what optimal diabetes care is, but that may not align with our funding system, our government, it may not align with our health system, and it may not align with all of our patients. If we only think about it from our perspective, we will not see the big picture and we probably will be struggling or fighting against the system. These are silos, these are wheat silos, and they're all across Australia. We've decided to paint them to make them look nice, but they are still silos. And that's what much of our health system looks like to our patients. If they're going to a different place for their pathology, to a different place for their cardiology, to a different place for their diabetes care, they can spend a full-time career going to all the disparate places that they're trying to get their care provision. The other problem is we often will look at a problem very much from our own perspective. So we go down a rabbit hole, so to speak. In other words, we only look at the problem from a very narrow perspective. There's a strong argument that what we need to do is flip the paradigm and not necessarily see the problem always from our own point of view, but actually see the problem from those who have diabetes or are at risk of diabetes. So flipping the problem so that we understand the problems and we understand the solutions. So the first thing in diabetes is understanding the problems. I'm sure we're all aware of the global burden of diabetes. In 2021, there was 529 million, the vast majority with type 2 diabetes. The prevalence was 6.1%, and 52% of that burden was due to obesity and rising BMI. By 2050, it's projected that will be 1.3 billion, and most areas around the world will have a 10% prevalence of diabetes. It is incredibly unlikely that we will be able to continue to provide individual healthcare in the way we are currently doing it to 10% of the population, let alone being able to focus on, or not focus on, prevention as we currently do. So we need to address this problem at a very big public health level, and I won't address that here today. But if we understand the problem from the patient's perspective, almost every hour, waking hour of every day, they're living with diabetes. They're the ones who are moving or not moving, eating well or not as well, testing their sugars, looking after their complications, administering their medications. They will see us for a very small period of time in a total year. And to think that we are largely responsible for the control of their diabetes is a problem of that understandoscope. So this is a condition where it is largely up to the individual with their social support networks, education and health services as part of that on how they control their problem. And increasingly we're seeing a move to all sorts of support strategies for diabetes that will involve us, ideally, but are also additional to us. That includes using digital technology. We've seen continuous glucose monitoring, we've seen insulin pumps emerge, we've seen a range of new digital tools to help our patients. Those are much better used if they're used with us, if they're integrated into our care, which means, again, we need to see that perspective from the patient's point of view. And if you think about what happens when a patient has a diabetic emergency, now some of them are very good at this because they may have many of them, but the reality is if you have an immediate diabetic emergency, from our government point of view, this little box over here is what they think happens. The patient has a problem, they come to the hospital, they get managed by the hospital and they go out again. And we know that's completely not what happens to the majority. In the ideal case, they would get support when they first became unwell. You could be part of that network, it could be community health, it could even be family, but there is a range of different complex providers that person can go to. And if we don't think about that system and optimise the way they engage and become part of that system, then they will keep going in and out of hospital. And indeed, diabetes is now the #1 preventable cause of hospital admission in most countries in the world, largely because of this mess. Because we haven't thought about a way to address the system, and there are places that are doing that. There are places that are integrating healthcare, social care and medical care and actually coming up with much better outcomes. But if we're going to drive a change in our system, and this has been shown very well in India, as I said, in India and in the South Asian region, that we need to understand all the people who are important in changing the system. That includes the individual, which is the patient and their family, but it also includes ourselves as doctors and providers. It includes the organisation, which is our health services and our community care providers, and it includes the system that we're working within. If we don't understand those things, even in the context of our practice, it's unlikely we're going to be able to offer an integrated care program for our patients. So if we think about that, the outer setting or the system is what is the culture in the area you're working in? What is the practices around diabetes? How is it perceived? Do people actually seek and can they access care? What are the policies and systems and things that offer opportunities for those patients? The inner setting is what your organisation is like, which might be your local health service, hospital, outpatient or private practice. What is the structural characteristics? How does that actually function? Is it an all-in-one stop shop like we saw in the example in the last talk, or is it a sole provider who just provides consultations for diabetes? So what is the nature of the service that you're working in? And then the individuals involved. Again, if we don't understand and work on improving their knowledge, beliefs and attitudes and looking at how we can help support them, that's going to be a problem. Our patients may, as we heard in the last talk, want to talk about whether or not they can eat a banana, and I'm sure they've got a lot of questions they want to ask us. But again, if we seek to do that one-on-one, individually for every patient, that's going to be very challenging. But if we can link into evidence-based, reliable, simple, accessible digital education tools and we can make sure they're reputable and refer our patients to those, our patients will get a lot of the information they need without surfing the internet and misinformation, and just be able to raise the critical questions they have that emerge when they see us next. But if we don't understand that context, we won't be able to support them. Then we need to know what actually works, what is effective in terms of being an intervention, and then how we adapt it to our context. For example, artificial intelligence was mentioned before. It can be fantastic, it can also be very challenging. And if you are going to look at artificial intelligence interventions, you're going to need to know that they work and that they are effective. So if we think about what that means you need to understand who the people are that are stakeholders. You need to understand and be able to link to your community, and that's not just your own patients, but your patient support groups as well. And that includes things like local government, other health services that you may wish to integrate with. So what are the policy contexts that you need to fit into? What is the opportunity within your organisation to improve the systems? And always see this from the person's perspective, not your individual patient's perspective, because you have a doctor-patient relationship with them. If you ask them to come in and tell you about how to improve your practice or your health service, you may end up talking to them about their own HbA1c and their own private diabetes management. This is about community members who have diabetes, who come in as experts in the lived experience of diabetes, and having them involved, for example, being an advisor to your service or your practice, is completely different to just asking a patient to come and tell you what you wanted or sending out a survey. So respecting that patients can bring, or community members can bring a great deal more is really, really important. And you will now see this in all the best centres that are in most of the high income countries will have a patient advisory group, and they'll bring those experts in to give them that understandoscope, different perspectives to their own patients. And then when they go to drive an initiative of change, they make sure it's evidence-based, they set their objectives, and they work through driving that systems change. One of the problems is, even if you understand the system you're working in and you bring in your patient and community to know what to change, it's hard to know how to make change. And this is one of the challenges we were working on with groups around the world about how you effectively drive change. So we have undertaken a very large project on improving health outcomes, and we've used a big focus on data. If you can't measure something, you can't show it's improved. And that's what we do with our patients with their HbA1c and their cholesterol and their blood pressure. But we need to do it on a practice and a health service and a regional level to be able to show that that's actually changing. So we set up a governance model which had international experts. We undertook best practice evidence synthesis to look at every example in the world for any condition where people had looked at a learning system on how to improve healthcare and had shown a benefit. Surprisingly, there are not that many of them. And from that, we adapted a learning health system model, which essentially said we were going to bring those 4 quadrants together: evidence from our stakeholders, our patients, our community, and our context, evidence from research and guidelines, evidence from what we currently do in practice, so our data, and then evidence from improvement when we try to drive change. If you bring those 4 things together in that order, there is very good evidence that you will make a difference. However, if you just go and drive an improvement initiative without knowing that it's important to your end users, without knowing what is evidence-based, without knowing what your starting point was so you can't measure if you improve, then it's very unlikely you will make a difference. So those 4 very simple steps, always starting with what's important to all those around you, is the recipe to make a difference. And there are many publications around this. Indeed, our group are now one of the leaders in learning health systems, and we're working with Qatar, New Zealand, the US, the UK, and Canada around implementing these systems in diabetes. But the principles are simple. So what is the problem you're trying to address? Are you trying to provide better integrated care for patients in your area, or even your region, or your country, or your practice even? What is it from those stakeholders that they would need and want, not one-on-one, but from a more collective group of people? And therefore we need the advice of that patients and community involvement so that we all know this is the problem we're working on. Once you understand the problem and make sure you've got all the stakeholders, you can then set priorities around what you're going to tackle next. critical to use evidence. Most quality improvement initiatives around the world are run by accreditation or quality improvement people, and they do not necessarily use best practice evidence. But there's really good evidence about what works, so really good to use evidence first. But in India, the evidence may have been produced somewhere else and may not work for you. So you will need to adapt that intervention to the culture, to the context, and to the system. The third one is evidence from practice. What are you trying to improve that's met the priorities of your stakeholders, that is evidence-based, and how are you going to measure it? Because you're going to need to start with that measurement when you start. And then finally, when you drive your change, putting in digital education to enhance your healthcare, integrating other aspects of healthcare into a one-stop shop, integrating artificial intelligence, whatever it is, make sure you measure it to start with and make sure you measure it as you go along so you know you are improving and driving change. If you measure it, you can also show that it works not only in your own practice, but you then become a benchmark or a quality practice or health service that can teach others and bring others on the journey on how they can improve. It's also a lot easier to get funding from other agencies, including government, if you show that you use a system that actually drives improvement and you can measure it. So we've done this now in diabetes, in stroke, in cancer. We've done it in gender equality initiatives, in community involvement, and improving access in remote regions. It doesn't matter what you apply this very simple metrics to, it works. So just finally, I'll give you a bit of an idea of a case study. This is the Monash Health Diabetes Service, where I was the director for about 10 years and he recently stepped down. It has 8 hospitals. The big brown one at the top there is Australia's first dedicated heart hospital, which is only for cardiovascular disease. 65% of those patients in there have diabetes. It has a large quaternary hospital, a children's hospital, an aged care hospital, a mental health care hospital, and multiple other large community hospitals, and it's the largest health service in Australia. We provide, probably small for what it is in India, we provide about 50,000 episodes of care directly in diabetes each year, and that's from pregnancy to paediatrics to adolescents to adults to older age. And the most important thing is, whilst we provide those directly, we support care for hundreds of thousands, if not more than that, in the community without directly providing that. And so to work out what our model of care was going to be, because we had 18-month waiting lists to come and see us, and care should not be based in a hospital if you have diabetes, is that we got everyone together and identified our problems: delayed diagnosis, poor prevention, significant diabetes burden. That squiggly line I showed you before, very complex services for our patients to penetrate, very poor integration, wasn't really focused on what the patients needed. And so we got everybody together, set up partnerships, and aimed for the priority that we all put together, which was to have much better integrated care. We pulled out the best evidence of integrated care in models that hopefully would mean that in our hospitals we would see as few people as possible. So our objective was we would succeed if we had as fewer admissions as possible. Doesn't work in a private system, but this is a public system, because they were being well cared for in the community. The next level down was our chronic disease management clinics, and again the aim was for us to only see the bare minimum. Then we had support services where either community endocrinologists or diabetologists or general practitioners or physicians could refer someone in for intensive short-term management. We only saw them twice. We were never allowed to see them more than twice. We got them back on track and sent them out again. And then the other ones were supporting care in the community and then educating other care providers and then educating our community. And by structuring it like that, with clear measurable targets on what we wanted to achieve, we were able to transform the whole service. But we measured everything first, looked at how our patient journeys, our integrated care, our admissions, our wait times, our numbers in all those different levels, adapted it for our context, and then actually put it into practice. We made sure we had primary care data, hospital data, and government data, and we kept continually looking at what we were doing. We set up new models of care, we partnered with all the different agencies, we set up networks, very focused on supporting care for diabetes in the community and linking them into the support whenever we needed it. We had community-based models of care, very limited tertiary care, and we did have some acute services expansion because our population was increasing. Australia has 40% of its current population are immigrants. In my particular area, 65% of people who attend our health services were born overseas. So first generation Australians, and the majority of those come from India and South Asia. So we have a not dissimilar population in many situations to many of you. In doing that, in taking that approach round and around and around that cycle of improvement, we have managed to show a very significant improvement in models of care. And it wasn't about which drug we were choosing, and it wasn't about what was new in obesity management. It was about taking a much better systems approach so that our private practice endocrinologists could link into our services if they really needed them, so that we were only doing the work we needed to do and we were supporting everybody else, including our patients, to have what they needed. So we made sure that the outcomes were co-designed, we did it in partnership, we improved both public health and primary care programs. It's actually much more than 30,000 now, it's up to about 40 to 50,000 directly, but much broader a reach in the other services that we now put out there. And we have less use of acute services. In fact, the patients that come in with diabetic ketoacidosis now or hyperosmolar coma are either new diagnoses or they're recurrent offenders where there are social issues. They're homeless, they have mental health challenges, they don't have a job, there are other issues. And in fact, now the current model of care that we're establishing is in collaboration with Canada and the UK, and is based on social prescribing to support those who just cannot manage their diabetes. So we're going to leave it there, and Sanjay and I will have a discussion with all of you. But what I was trying to encourage you to do is not just see your practice or your health service or your patients or yourselves in isolation. Unfortunately, as doctors, we are trained for patient-doctor one-on-one interaction, and we don't always think about or understand the system and the service in which we work. It doesn't take long to spend a bit of time understanding that, and it will, in the end, give you much better care and much better practices. Thank you.
Thank you, Dr. Helena. And you've put things in perspective for us. So yesterday we learned about various aspects of diabetes. Today we've talked about our practice in the morning, how to set up a practice. But now suddenly we are thinking beyond the box, beyond our practice, and we are thinking about the community, the country that we serve. Any questions, any thoughts coming to your mind, any comments? Any butterfly thoughts? So what does the systems approach mean to you? Professor Hamid, any thoughts coming to your mind? When you work in your institute, do you work in isolation? Are you dependent upon other people? Are you independent of everyone? Or are you interdependent with others?
So this is very important from our own perspective if you talk about the management of diabetes in India. The current scenario is that everyone is independent of each other. We don't talk with each other, we don't have a two-way communication with each other. We being a government set up a tertiary care center do get a lot of patients from referrals from those doctors who know us personally. They are sending that with that, but we don't have any system in place. Because if you talk about management of diabetes, then definitely a large number of patients, they can be managed at the primary care level very well, with minimal training of the doctors and the paramedical staff. They can be managed very well wherever they are. But a certain subset of patients, they do need specialized care. When to refer, whom to refer, where to refer. And as ma'am has already talked about data, another thing which we lack in our country, we don't have an organized kind of data. So definitely if we look at the management of diabetes from a country level, then definitely we need to do a lot of new things. We need to have some kind of command where we can have from state level, central level, to the PSC level, that is our primary health care center. So definitely I think if we will be organized, then the outcomes will be much more in a better way. So that's what I want to add.
Thank you. So we need to focus on data, and we need two-way communication between all the various levels, primary, secondary, tertiary. Professor Maskey is from Nepal, and he is a member of the executive committee of the International Society of Endocrinology.
Hello, Dr. Helena and Sanjay Kala sir. So Dr. Kala has already told me. So in BPKHS, what we are doing for diabetes care is like we are focusing on student, MBBS student. So we have made a wing, student wing for, we are told them to write a motivation letter. We have started with diabetes food care team because that is neglected and in the Nepal. So we started with that. So students have written motivation letter and we have got 100 of applications. So we will be selecting 20 out of them. So we have to target from the student level, MBBS level. So not only teaching them and not only giving a lecture to them. So we have to make them a team and they will help us in every aspect. So whether we are conducting conference, whether we are doing a community outreach program. So we are doing on that. So within 2 or 3 months we'll be starting that. So we have to focus on it, the course and curriculum of any medical college should have that. I think we have to start from that, and definitely we have to have a government support and system and whatever the Dr. Helena and you have told. So this is my comment and feedback on that which we are doing in Nepal. Thank you.
That's a nice take on leadership. So as a leader, you engage the medical students, let them work in diabetes care prevention, and also they become leaders for tomorrow.
Yeah.
Dr. Helena, I have a question. You used these simple words, co-design, work together, interact with each other. How do you get 2 alpha men or 2 alpha women together at the same table and ensure that they do not fight with each other or fight against each other, they fight together against diabetes? How do you do that? And I see smiles from many alpha men and from some of the alpha ladies as well. Thank you for your smile. It's a beautiful smile, Dr. Meenal.
It's an important question, but it's not that much of a secret answer. So again, in medicine, we are trained very much one-on-one. We think we're very intelligent, we work very hard, we see our patients, we have a problem in front of us and we fix it, and we generally do it usually by ourselves with the help of a few other people. Our training does not really train us to do things as a team or collectively. And as I said, I had the opportunity to do an MBA early in my career, and it really made me realise that leadership is a recipe, and that if you follow it reasonably structured, you'll be okay. I don't think it's so much alpha males or alpha females. I think it's any group of practitioners from any background or stakeholders coming together for the same reason. When everybody is in the room focused on themselves, their practice versus my practice, my region versus their region, I'm a diabetes nurse versus... In fact, the worst ones I've had to work with are obstetricians and midwives, because they fight over the fundamental territory of who should be delivering a child, and that's really challenging. But for many decades now, the way I bring people together is largely around making sure we're there for the right reason, which is the patient story. So that's not our patient, that is a patient journey or a patient representative or a lived experience. We start every meeting with a patient story, not necessarily tragedy, sometimes a really good patient story, but putting everyone in the room around the table to make sure we all know why we're there. Yeah. People are still going to have their vested interests, but patient stories are really important. The other thing is accountability and transparency. People need to be in a room collectively when decisions are made, so they can influence that decision, but when they walk out, they know it's a collective decision, which means you need governance, you need committees in terms of reference, you need process. It's not bureaucracy, it can be very efficient. In fact, I'm in the middle of leading one of the toughest things I've probably ever done, which is we are changing the name of polycystic ovary syndrome, because it's not an ovarian disease, it has a male phenotype and it's not just about ovaries. And to get everyone together for that was incredibly difficult, but we managed to get everybody together and are going through a formal process to do that. So it can be done, politics can be overcome if you have all the stakeholders in the room, you break down the power barriers, you make sure the patients and their outcomes are at the centre, and you use governance and process and transparency to get there.
Thank you, Dr. Helena. So process is accountability, but keep the person with diabetes at the center and make sure you repeat that again and again. And I was just discussing with Dr. Hamid, we are now working on a risk stratification tool for patients living with diabetes and chronic kidney disease for Ramadan fasting. And how do you get different people together? You just remind them, who are we doing it for? Not for ourselves, but for the person living with diabetes. And once you keep on repeating that, which is the truth, automatically everyone aligns. Dr. Helena, before we conclude, any questions, any comments for the audience?
Only one, just to encourage you to think bigger than yourselves and your practice and your immediate region, because almost always someone else has tried to do what you've done. They may have failed, they may have succeeded, but you can learn from them. We just finished our Ramadan policy for our health services. I'm sure there are many, many more, and looking at those and then seeing how you need to adapt them might be an easy way, for example, or us looking at yours. So you don't have to do it alone. And the best thing about learning from others is you don't make the mistakes that they've made before.
So we work together. Thank you. Now the funny thing is, I come from Punjab, from Haryana. So when we talk of butterfly in Punjabi literature, our songs go like, why don't you be a butterfly, let's go together to the farm, and it's very naughty, romantic kind of thing. But suddenly when you come to Ahmedabad, your hormones change, and now the butterfly effect for all of us means that we all, when we go back, we become leaders in our countries, in our states, in our cities, and we lead together with each other. And the final aim, just remember, that is health of the person living with diabetes. Thank you and Jai Hind.